and we're good to go. So, Anurag, please enlighten us.
All right, let me start sharing my screen.
Sure.
Did we get there?
We're seeing you about to start the screen. There we go. It's good. Just expand it now.
Let me get to slideshow mode so everyone can see better. Are we there?
We are there.
Okay. Good morning, everyone. I am presenting Abada Health, but I thought that I would take a non-traditional approach to the presentation. Back in 2018, January, actually, is the first time I presented, I believe. And it was on a project called Helix. And so I thought I would give you guys a timeline of what's happened since that first presentation until now. And if there are any questions, you guys are more than welcome to just interrupt me, or I'll take questions at the end. I thought I would maybe go more in depth into any of the products or analytics that we ended up getting into later in the presentation as a Q&A, if that was, but didn't want to bore you through the timeline because there was quite a few things that happened. So this is a story about Abada Health or Helix. And that story could take many different turns or many different views. It could be a startup story, it could be a research story, it could be a business story. And so even in this slide, Abada Health, what are we? It depends on who you ask and who I'm talking to, right? So what we really do is we move data for organizations or healthcare data specifically so that they can more effectively get a handle on it and use that data for either better health equity or data-driven decision support, but transforming their data into insights. A little bit about me. I'll just say long-time lurker, second-time presenter. I'm founder, CEO of Abada Health. We have expertise in HIPAA data security and privacy. We do predictive analytics, resource optimization, clinical decision support, and then we built more recently a health equity index. So what's the goals of this discussion today? It's to show you guys the evolution of Abada Health, even through the COVID-19 epidemic. Where we started was what was called a Helix chatbot. I'll give you guys the timeline, which is the bulk of this presentation, and talk about our products, which is the following three. All right, Helix timeline. So like I mentioned, back in 2018 is when I presented about Project Helix, and it was in the very, very early stages. What had happened back then was a community under Digital Drive had applied to a Robert Wood Johnson Foundation grant in which they wanted to figure out how to give more information or empower patients with more information on their pharmacy practices. And so there wasn't really much structure into what they needed. But what we had presented to them was, what if we created a chatbot that would be able to connect to multiple different data sources and present the patient with the information they need to make their decisions? Would that be acceptable? And they accepted it. And so we needed to go do some of that uh, work in the form of gathering information from our community, ideating concepts, creating an MVP, and then eventually creating a product. The problem that we were trying to solve was back then, which is currently about the same as today, about a quarter of your medication costs lower off insurance than on insurance, but the pharmacies still don't have the right to tell you that. So you actually have to ask them for it. Behind the scenes, there's gag orders and all sorts of agreements between insurance companies and uh, pharmacy benefit managers in your pharmacy to help make that a little bit harder to get. And so we thought, what if we just ended up doing that through a mobile chatbot that you could work with? So our first version was this chatbot called Helix. Helix was a little robot that would tell you what you needed to know. The chatbot user experience included us figuring out where you're located in the world. So we used geolocation services. We integrated with payer accounts and their APIs. We understood your current, what's the word that I'm looking for? Deductible. And then we would tell you based on the prescriptions that you had entered, um, where the cheapest place to get your medication would be, whether it's the local CVS, the KU pharmacy, or even Costco. Is it cheaper to get it on insurance, or like just look at the pricing that they have there, and then send you a map of where that would be, and then like a screenshot of the pricing that you should expect. Um, Initially, it was pretty complicated because we had to go through multiple different APIs and do calculations on the back end. We also needed to make it secure. So the chatbot started as a text bot. And then as soon as we needed to get personal health information or not, personal information from you, then we would have switched over to a secure mobile version of the chatbot that looked similar. So it still looked like and acted like a text bot, but you were on a different portal that allowed you to enter some of that information in. So we would be collecting names, date of birth, insurance information, and then your pharmaceutical like prescription information that you needed, and we would spit out an answer for you. Let me go back. So we thought we were doing great in that time. I think this was a couple months after we had presented. What we realized that after we had done some pilots and we had actually had some traction with customers, the value of this chatbot was only as good as how many times we could send messages back and forth to patients. So it was really just the text messaging system that ended up becoming the business of the chatbot. There were a variety of different paths that we could take, including patient information, consents, scheduling for clinics. But again, we were looking at pennies per communicate, and that was really hard to scale a business on. So during that time, I was still working on research, and some of that research included machine learning and predictive analytics in the sepsis space. But it was really just a proof of concept or a model that we were looking at trying to mine healthcare data and understand if we can build prediction models. And so those models look a lot like this. What we were doing is clustering patient pathways and understanding phenotypes to see if we could look for positive and negative like health outcomes. And it was pretty much all automated. The last set of models that we were looking at looked at about 10 to 20 billion data points and about 100,000 patient encounters. And we would build the pathways automatically through our models, and then the models would then, the models being those phenotypes would be associated with different pathways for patients that were going through the process of sepsis, from time zero being when they entered the ER to discharge. The previous page with some of the publications on that. If someone wants to know more, you're more than welcome to ask. But the reason why I bring this up is because this is what ended up becoming the next version of Helix. Helix then became a clinical decision support tool for diabetes management. And in about 2019 is when we first finished that product. It was something that we could actually deploy with clinics. We would take their medical records or the clinical information, and we'd be able to help them predict which patients are likely to fail on their treatment protocols or their standards of care outside of the clinic, and present them with some clustered solutions on what interventions they could use. And while we started our sales at the end of 2019, we ran into COVID in the first quarter of 2020. And so all of our partnerships stalled. Everyone said, hurry up and wait. We have this other thing that we need to deal with. And so let's see what we can do in a little bit of time. So during that time, and about in Q2 of 2020, we created a second version of that predictive analytics tool, or that clinical decision support tool. What it did was, instead of just working for diabetes, we also were in the background working with asthma and hypertension. We looked at what if version 2 was for COVID specifically. And so those COVID comorbidities that I just happened to mention overlaps with what was going on with COVID. And so our second version looked at some analytics for COVID-19 patients, or or future COVID-19 patients with current COVID-19 comorbidities. So it wasn't a huge change in our model or our analytics tool, but it was a different presentation, a different output. And so right after that, we added our first clinic, which was about 25,000 lives. Through that process, we realized that we had lots of data integration issues. We had started seeing that in the first version of our product as well. We would have clinics, or we'd have health systems that would be interested in working with us. They'd say yes, we'd sign a contract, we'd go down the chain, and then when we asked for their data, they wouldn't know what to do. So it's really hard to work on data within an EMR. It's really hard to export data out of an EMR and put it somewhere, and so that we can work on it. And that became the start of another process that we're looking to solve. So data security became a big piece of what we looked at the end of 2020 into 2021. And so we built a data security environment so that we could do our analytics, and that eventually ended up becoming Abada, the second product that we had, so Abada Vault. But that's an easy, clean timeline. Let's go into the upside down. What ends up happening at the same time? In 2019, Helix gets sued for copyright infringement. Helix apparently gets trademarked out in California right before the pandemic. The company that is Helix OpCo ends up getting about $600 million in VC money, and so their lawyers go to town. We decide that it was probably best to let go of that trademark, even if we had worked on it for years beforehand. So over that next year, we transition to looking at what we could potentially be otherwise. COVID-19 happens and Helix works. So we, not as the product, but we as Helix starts to get involved with local work efforts. Digital Drive was one of them. But a variety of different public-private partnerships start occurring in the scenes behind the scenes. And one of the things that we start realizing in 2020 was that Kansas City needed better data sharing infrastructure. I think a lot of different groups started trying to get involved. Some of them were very large tech companies here in town that were slow and pretty expensive, couldn't help initially. So we all start to get together and create a pilot. And the pilot was to try and connect a number of health departments and hospital systems to address testing, vaccine mismatches, patient requests in the form of where to go to get a vaccine, where to go get tested, et cetera, et cetera. And so we built a first version of a data environment that could anonymously verify data in neighboring environments. And it took us about 2.5 months to build. So looking at it from the other side, that was the first data security product that we created to help Helix or Abada do its own work. It was an overlap with some of the work that we were doing in the community for COVID-19. Some versions later, I don't know if it was version 3 or what, or even farther out, we ended up making the data security environment much more efficient. So we could integrate, or we could deploy those environments in 48 hours instead of 2.5 months. We integrated them into our health system, or sorry, our Abada Health systems. And so it became a feature set. When we went to go out and deploy our analytics to our customers, or we would go through sales, we would also talk about a feature that we had, which was a data security product or data environments that allowed us to do the analytics, the predictive analytics they'd like, but they would never lose control over their data. So it was a joint venture concept as well. That's one of the features of the security environment we have. They let us get access to their data, but we don't actually take their data anywhere. Once we're done with the analytics, they turn off access to that data, and they could either destroy that data or they could take it back into their own system. Anyways, that was something that became another lesson for us. We had a number of clients that said, hey, we really like what you're doing here.
Morning,
Linda. We really like what we're doing here. But we're not ready for the analytics that. Can we just buy your security system or your security environment, because we have other work that we'd like to do? And initially we kept saying no, for a variety of reasons. One of them was that we wanted to focus on our analytics, but the other reason was that it wasn't a product. There was no way for us to actually issue environments for other people outside of our company, usernames, even maintaining those environments or managing them. And so we took a good portion of time to understand whether or not we wanted to build out the security product as an entirely different product, or sorry, a security feature as an entirely different product or not. And at the end of 2021 is when we decided, yeah, we're going to take the next 3 months to just build it out, see how it goes. And if we can make a sale within the next 3 months after that, so first quarter of 2022, we will keep going with Avada Vault. If not, then it's just going to stay as a feature set for our analytics. So I'll say like back then we weren't quite sure. Today, Abada Vault is our biggest product. It's the thing that we sell the most. It's the thing that everyone probably knows us for, as far as our customers go or our clients go. And then the analytics is an add-on. So usually people want to do their own work or they have other third-party analytics that they'd like to bring in, but they don't have a place to do it. And Vault is the place that they can do that. And then the analytics that we would provide or anyone else would provide would be a layer on top of that. And so after that, we ended up this past year-ish, beginning of last year, or into this year, created our third product. So again, during COVID, we saw a lot of work that was being done that would say have large gaps in health equity. And we were wanting to present different ways that we could use data to help distribute resources in a population to reduce that gap. Social determinants of health was one of the big areas that we were looking into, as well as we did. And then at the second, or another part of this is that we were trying to see if we could also help enrich data behind encryption layers. So those security products that I mentioned earlier are encrypted in multiple different levels. Essentially, what that means is that anyone that is trying to look at the environment won't see anything unless you go through multiple layers with correct access to get to the data. But what if we could help enrich some of that data, or what if we could help work on some of that data without actually being able to see that data, was what we were trying to do. And so this was a good match in like looking at large population data, seeing if there's ways to enrich that data for health equity gap reductions, or help look at health equity. And so we looked at a lot of different models or health equity indexes, many of them published by the CDC and EPA eventually. And we built our own model that looked at different social determinants of health data, as well as place-based data, as well as about 200 different other data sources, and created an index. So in the middle of 2023 is when we actually, this is wrong. Don't look at that. Don't look at the rest of this, apparently. I guess this is the slide is incorrect. So we created a model in the middle of 2023. And that model will look at every single patient in that population and create an index against many different dimensions. So a financial index, a health index, education index, et cetera, et cetera. We have 19 different areas that we specifically look at, and it helps clinics understand how to prioritize the need within that population for a specific dimension. And so it's kind of moving past I think actually I do have some slides here. Yeah. So it's looking past the actual source of difference of health data and using it as a way to empower whether or not an individual is resilient or vulnerable in certain areas. So the bundles that this is presenting are different large areas that we've looked at. So an environmental bundle, a social vulnerability bundle, and then a health vulnerability bundle, and then overall score. And that, again, is just a way for has to help clinics with prioritization within a population. Another way of looking at it is if you have 1,000 diabetics and only 100 units of work, how do you equitably distribute those 100 units of work against those 1,000 patients, knowing that even though every one of them needs some help, who needs help now that could benefit uh, from an intervention earlier to help reduce some of those health equity gaps. So we stopped thinking. So part of that problem was that we had stopped thinking past the concept of social determinants of health in the healthcare space. Um, we think that collecting that data has a low value, and once it is collected, many people say that there's too much data and it becomes a problem. And so that health equity index was a solution to what we're looking at. Again, it's a zoomed in way of understanding dimensions and clusters. How do you cross air pollution with asthma? How do you look at hypertension, walkability in parks? What does insurance, transportation, and work status have to do with the access to healthcare? Um, and in the end, this is just like a process slide that kind of collects all of our different products together. So first is the Vision product, that is our predictive analytics, the Vault product, which is our security, and then our health equity product. But it looks at different institutions, whether it's identified or de-identified, and then brings it into a vault to help you understand how to pull that data together. We have another technology in the back end. It's not a product. It's called OneID. It uses another machine learning model to help identify records that might be owned by the same person and connect them without actually having all the PII available, and then presenting it to researchers and clinicians as needed. In general, here's going to be our ad. So what we're looking for, we are looking for connections with partners that are doing collaborative research or that have no institutions that are considering outside data analytics, but that are concerned with their data, or institutions that are wanting to help bridge the health equity gap and don't know how to move past the S2H data. Clinical and data partners would be great as well. Advisors are always welcome. Strategic connections. And then in the next 12 months, we're looking to cover an additional 100,000 lives. I know I went through a lot. I was hoping that if you guys had questions, I could address them or go back into different slides if you guys want to go into more detail. But I thought that maybe giving you guys a timeline would be most helpful. But thank you guys, and I appreciate you guys being here for my journey.
Thanks very much, Anurag. I really am amazed at kind of the evolution of the solution or and solution set that you've arrived at. You've been able to pivot so excellently along the way. It's just remarkable to me. Um, can you say a little bit about the idea of institutions or clinics working with their own data and not having to kind of give up their data? How does that play into what you're doing?
Yeah, I think one of the biggest concerns that we had heard earlier on was we'd like you to work on our data, but our data is invaluable, it's priceless, and we can't let it go. And we didn't know really how to get over that concept. So that joint tenancy concept is what I think we ended up coming up with. It is an edge service. The way that we describe it, like in a narrative form, is that instead of us going into your house and walking through your messy kitchen to get to your data, we build a shed right outside your house where you can store the data. There's little lock boxes and locks on there's lock boxes in the shed and a lock on the shed. And you give us the key to work on the data when you need to. We go in there, do some data analytics, build some reports or some insights. And then when you're done, you kick us out and you change the locks or you move the shed or take down the shed. And that's kind of the concept. The data really is sitting in an environment that's on the edge of their and they have full control over when someone comes in and when they want to shut it down. They're not really giving that data up to another tech organization or another health IT company. and then that data is not then being worked on, or I guess like managed through a third party by that institution. The institution actually manages it themselves if they want.
That's great. I mean, there's so many interesting concepts here that really play out. But let me turn to others. Steve Sewell, did you have a question?
Yes, great presentation on an amazing amount of work. I'm wondering about the multiple organizations that are attempting to do some of the same things in the equity space and in the population space. Unite Us, for example. How are you coordinating with some of those other? I don't know if they're not NGOs, but they're grant-based organizations.
Well, we don't really coordinate with them. I don't know um, what a I'm not sure if I have gone down that path far enough, I guess I would say, with them or other NGOs. Um, this is me thinking off the top of my head, but we would be more complementary. We're not working in the same space. Unite Us and some of the other organizations are in, and I'm doing a very generic answer to this, but in the business of collecting some of that data and representing it back to the organizations or taking it from one place and offering it to another place. Um, much of that index work that we were talking about is again in the predictive analytics space. So we use the data that's available and then build out and calculate out the rest of that data. So that's why we're not saying that we're in the SDOH data space specifically. We are in the health equity index or space. What that looks like is allows you to make decisions, and then you verify that data when a patient comes in for a point of care contact. Um, so it's still in that predictive space or the analytics space as opposed to the data collection space. Does that help answer that question, Steve?
Well, I think I mean, it's definitely a Venn diagram. You're
Yeah.
overlapping with other organizations out there, and it's interesting in a purely private situation. You know, you're competitors, but in a situation where you've got other organizations that are getting different kinds of funding, um, public funding, it seems like there would be some collaboration opportunities.
Yeah, absolutely.
Thanks, Steve. Doug Houlihan.
Yeah. Yeah. Just verify. Did you say 25% of people can get their insurance or their prescription drugs cheaper without their insurance?
Don't quote me on that for today, but it was so shortly in the past. But like, yeah, it was about a quarter of medications are actually cheaper off insurance than on insurance.
Okay, interesting. Yeah, because 50% of people don't follow their treatment plan that causes 125,000 people die in the United States every year. 3 million people die around the world from health medical errors, 50% due to medication errors. And the question is, what are the medication errors? Are they people not adhering to their medication because they can't afford it, right?
But
So
do you
these are
think
some of the questions I have.
yeah, I think I do think they differentiate between medical errors and adherence problems, but part of adherence is the cost of medications or the cost of care. So I think that, yeah, I think that still adds to the problem. Whether it's a medication error or, cost or transportation issues that prevent you to getting medication. But yeah, adherence, compliance both fall into, as well as medical errors fall into the categories that lead to the poor outcomes that we're trying to prevent.
Well, no, really appreciate it. Yeah, I mean, the thing I'm focused on is like automated vehicle technology. Right now, 1.3 million people die in the road system. So my question is when will we save 1 million people's lives with AI technology to automate it? Now, unfortunately, actually, road deaths are going up. I asked the same question about medicine. If 3 million, according to the World Health Organization, if 3 million people around the world die, supposedly somewhere around 250 million, 250,000 here in the United States die from medical errors. When can we, save 1 million people's lives to reduce medical errors? And can AI help with that? So those are some of the things I'm interested in. So some of your statistics and, what tools can people use and clinicians use to lower medical errors, I think is absolutely critical. So I appreciate what you're having to say.
Thank you, Doug.
Dylan.
Yeah. First, just want to say I really appreciate the presentation style of kind of giving the you know, public-facing clean timeline and then the nitty-gritty true story behind that. Just yeah,
I
I really
appreciate
like
it. I think
that. Um, and then just curious on the health equity index, what level of granularity is that? Geographic granularity or otherwise?
it's usually, well, um, we calculate down to the census tract level, but the data doesn't always come in that form. So different types of data comes in different forms. Some of them all the way are being all the way out to the zip code for the place-based data that we're looking at. But then when we're looking at building indexes, we build it for the individual patient. So we use that as like our funnel, but then look at the data records and their medical records if they have any that we can attach to them, and then end up with our final calculation. So the granularity of the index is down to the individual patient level, but like some of that place-based data comes in various forms from tract to zip code.
Okay. Thanks.
Well, just managing that seems to me like quite a chore.
Initially, it was, but now it's automated, so it's kind of nice.
Yeah, that's great. That's great. Other questions? Go ahead, Shannon.
Okay, I'm such an interloper and I am so beneath this incredible bar that you all have set so high. So forgive me for any um poor articulation of my comment because that's all it is. I was speed reading as you were presenting, and first of all, wow. But I have to say, for the very first time ever, I read on somebody's slide deck, and I think it was such a brave thing that collecting data has low value. I saw that on one of your slides, and I wasn't, you'd gone through it a little quickly, and I wasn't sure what that was in relation to, but it caught my attention. So I just wanted to ask what you meant by that.
Yeah, sure. I hope you didn't find any errors in grammar and punctuation, but it was littered. I think that we don't talk about it in a very overtly way that, collecting data has high value. Everyone wants to collect data at some level. Everyone thinks that they need to, just to be competitive. But I think when it comes down to the actual like cost versus benefit, collection of data has a super low value. Um, it's actually the things that you have to do afterwards with that data that start to bring out value, right? Whether it's data analytics or just reporting for efficiency or utilization uh, purposes, that's when you start to extract some value out of that data. And I think a lot of people in the industry forget that. So a lot of the costs or a lot of the projects, budgeting starts in the data collection space and then starts to trail off after that. And I just wanted to highlight that because we find that to be the issue many times over. Um, whether people are wanting to collect new data, already have collected data, they already have spent way too much. And so then there's very little left to actually do anything with that data, whether it's money or resources or even time. And so we again, this is in that predictive analytics space, are trying to move towards decision making with data, which doesn't require you to collect all that data. And so that looks very different. So prospective data looks very different than retrospective data. And retrospective data, what I think is interesting about it is like it should be there for record keeping purposes, for a medical record, for highly sensitive, highly emergent, like, highly important decisions. But general, like future looking predictions or future looking decision support doesn't require that much data collection and that high level of data collection. And I think there's also like different levels of data collection that then end up becoming more expensive. The last 10%, like the first 50%. And so that's a different way of thinking about data as well. So getting to a complete data set is highly expensive and has a very low value in many cases. And so even though people strive to achieve that, many times we feel like is a distraction to getting the work done.
Thank you. Very interesting.
You're welcome. Thank you for the question.
Anurag, do you have anything that would be like defined as the ideal client?
Mm, no. Some
No, that's okay.
of our larger clients that we've been going after, or some of them that are academic, are great partners, but they also encumbered by large legal and compliance and variety of other something teams that take a long time to get through. So that's been pretty burdensome for us many times, where we're working with one team and then another team and another team, and their resources outstrip ours. So that's there's challenges and like benefits to all sides. What we've been looking for um, a lot recently are um, partners that are specifically interested in working in their data on their data, but don't have the ability or the time to do it themselves. And so, at least for us, we can help them host that data for anyone to come in and work on it, whether it be us in the primary care analytics space or someone else that can work on that for them. And we've even white labeled that security product for them to do that. So I think that would be like one of our ideal partners, and they've been in the academic health center space, the small clinic space, the FQHC space. We've had public health clients. We have not had an insurance client yet. We've been working on different projects or different proposals with that, but have not actually partnered with an insurance company yet.
Okay. Yeah, that would be a
Morning,
great
John.
opportunity as well. Go ahead,
Quick
please.
question, John. For
Yeah.
some reason, I can't raise my hand. So, morning,
Okay.
guys. Jeremy Elias, founder, CEO at TrackMy, also a fellow UMKC RU, Dr. Patel. So, would love to catch up on that front. But a couple of questions here. So, I love the idea of data is useless or moneyless, if you will. It's all about making data actionable. So, I think the idea of the analytics and such, really strong move here. Question really is around kind of pricing strategy. And we have on our side, we do employee health compliance, public health, et cetera, tons and tons of data, millions of users at this point. But trying to nail down, thinking about a monetization strategy for that data set, the data structure. So, how are you guys walking into hospitals, pricing this out? Are you doing it on a per person basis? What's working for you? What's not?
Yeah, it depends on the product, really. So our analytics product is a per member per month rate usually. And then it's usually for a set of analytics. If you wanted another set, it adds to that, but the rate changes, I guess, based on the number of analytics that we'd want to do, plus the number of the patients. We usually do it in blocks because we don't want to. So one of the things that we looked at was like, how do we count the number of people that the organization has? And that's a service and a product in itself, and we didn't want to do that. So we look at quarterly patient panels for them, and run the analytics for them on that. For the security product, it's basically based on their data set initially, and then the volume of use that they have. So we have different ways to meter their use. And that security product can be something that we have turned on for a little bit of time, or that it's turned on all the time at a high availability with redundancies built into it. What that means is that we would have something that's available at 99.999%, and it has redundancies in two different parts of the country, so that if one server system went down, then the other one would kick back up right away, but also for backup purposes. And that is just priced on a product per month. So there's different tiers that we have, and we can kind of manage the size of those tiers. And then each environment has its own pricing to it. So you would have a main environment that can connect multiple different environments, and each of them have a monthly cost to it. And then our health equity product is mostly just has been an annual fee based on tiers on the size of their population. We mostly did that instead of doing a per member per month rate because of the type of work that needs to be done in that space and the clients, and we just want more people to use it as opposed to like trying to figure out how to maximize our revenue stream in that. Um, but also it helps us in the long run get that data to test out earlier on. That model may change over time, but it's really just a way for us to make it more accessible. Did that help, Jeremy, or do you have some more specific questions?
It did. No, no, that's great. That's great. I think there's a lot of strategy we could go over. I'll drop you a note here and do a follow-up. Thanks,
Okay, great.
Doc, and thanks, John.
You're very welcome. Thank you for coming. Any other thoughts before we end up today? Okay, well, let us leave it at that. Anurag, thank you so much. It's just remarkable to see the kinds of options that are within your solution sets, the fact that you've been able to branch into various products and so on. I really think that's impressive and look forward to seeing how you continue to succeed with that. So thank you very much for sharing with us.
Yeah, I appreciate the opportunity to present and share our story. But I think you're very generous, John. It was a lot of happy accidents along the way.
Yeah, well, that's good. That's good. I always need to know how to deal with those. So you seem to have done it right. Well, thank you all for joining us this month. We look forward to the next month. We'll be shortly sending out our October announcement and look forward to seeing you all here. We're also looking forward to a evening forum on December 9th. It's a Monday. It's not a Chiefs Monday night, so that's good. And it's going to be covering a topic, and Anurag will be helping to contribute to this about lessons learned from COVID. So we want to look at kind of how do we deal with the future pandemic? Are we ready to do that? And how do we need to be thinking about it? So that's December 9th. Go ahead and mark that on your calendars, and we'll be getting an announcement out on that shortly. Thank you all.
Thanks, John.
Bye
Thank you,
now.
everyone.